the aim of the study was to determine the etiology and outcomes of fetuses with non-immune hydrops according to the gestational age diagnosis. We had about 273 fetuses. You can see the table on your right-hand side, the list of the causes according to the diagnosis, the trimesters. As you can see, the commonest cause in the first trimester was chromosomal aneuploidy, and the commonest of them was Turner syndrome, followed by trisomy 18. And congenital infections were mainly contributed to hydrops in the second and third trimester, and the commonest was parvovirus, followed by CMV. Interestingly, despite all the investigations, about a third of the cases remained with unknown etiology. About a third of the cases had fetal intervention in the form of thoracocentesis, transfusion, or insertion of a shunt. In this group, they had significantly lower perinatal mortality, and in this group, gestational age diagnosis was significantly associated with the risk of perinatal mortality, despite the fact that the body cavity involved and the presence of polyhydramnios were not significantly associated with the risk of perinatal mortality. Regarding the outcomes, so you see in the first trimester, about 2/3 of them ended in miscarriage or intrauterine demise. In the second trimester, about 50% of them ended in intrauterine demise or miscarriage, and 40% were live-born, while in the third trimester, about 60% of them were live-born. So in conclusion, earlier gestational age diagnosis was associated with increased risk of aneuploidy and worse pregnancy outcomes, including higher risk of perinatal mortality. In our data, fetal therapy was significantly associated with a lower risk of perinatal mortality, but we have to consider the potential risk of selection bias. Thank you.
Excellent. There's one question from the lady over there.
Great presentation, Dr. Khalid. So hydrops is also my research area.
Fantastic.
So I'm wondering do you offer microarrays for your patients?
Yes.
Do you offer lysosomal storage disease testing for them?
It depends on the individual case. So the cases that have the array and it's normal, and we don't find other causes like anemia, for example, or congenital infection or something that requires fetal intervention, they have genetic counseling, and the genetic counseling will direct further detailed genetic testing, including exome sequencing, for example, or if there is family history, will be specific genetic testing.
So I'm doing whole exome sequencing on fetuses with negative standard workup. So we'll hopefully in a year or two we'll have more information for those who are undiagnosed.
I think that would be great because we have ongoing 2 cases where we can't find the cause. We don't have any etiology, and we know the prognosis is likely to be poor, but you can't do anything to help the parents, which is quite frustrating.
Yeah. I wish I can involve international patients.
I'm very happy to give them your details.
I have 2 comments to make, really. I would not have necessarily placed parvovirus in the group of the fetuses with hydrops. I would have considered them more to be anemia or sort of like the rhesus group. I find it quite interesting that in that group, CMV is the second biggest group. That is really surprising. And I find it amazing, the case number of 273 cases with fetal hydrops. Are there any more questions? Thank you for a fantastic, brilliant lecture, Asma.
Great, thank you very much.